Welcome to the Hepatitis and HIV Virtual Education Summit Series presented by Johns Hopkins University School of Medicine at ID Care Live. My name is Michael Ayala, and you are tuned into a live session called New Approaches to HIV Screening and Prevention, the Impact of Treatment as Prevention, PrEP, and At-Home HIV Tests with Dr. Bernard Branson. Before we get started, I would like to remind our audience that we will be taking questions in real time throughout the presentation. You can send me your questions anytime during the program through the box in the lower left-hand side of your screen, and we'll try to get to as many of them as possible. Now on to our guest. Dr. Bernard Branson is a medical epidemiologist at the Centers for Disease Control and Prevention. He worked as Associate Director for Laboratory Diagnostics in the Division of HIV/AIDS Prevention at the CDC, where he also conducts research into HIV prevention strategies. Dr. Branson has been the chief architect for the CDC's activities surrounding new technologies for HIV testing, including rapid HIV tests and tests for HIV incidence. Most recently, Dr. Branson was the lead author for CDC's revised recommendations for HIV testing of adults, adolescents, and pregnant women in healthcare settings. Dr. Branson has been involved in HIV counseling and testing for more than 20 years. And in 1983, Dr. Branson founded the AIDS community-based organization HERO, the Health Education Resource Organization, and in Maryland initiated the state AIDS hotline and Maryland's program for anonymous HIV counseling and testing. Dr. Branson, thank you very much for being with us. We appreciate it.
Mike, I appreciate it. I appreciate the opportunity today to talk about new paradigms for HIV and hepatitis C screening as they relate to many new developments with respect to prevention, especially treatment as prevention. First of all, I need to acknowledge that I have no financial interest to disclose. I will be using brand names during this presentation for identification purposes only, and of course these findings are not necessarily the official position of the Centers for Disease Control and Prevention. I want to start talking out about terminology. I think most clinicians are used to doing diagnostic testing, which is performing a test based on clinical signs or symptoms. Targeted screening is what we really have been doing for HIV and HCV, which is performing a test on subpopulations of persons at higher risk based on behavioral, clinical, or demographic characteristics. Screening is really what we're now advocating, and that's performing a test for all persons in a defined population. And in particular for HIV, we're recommending opt-out screening. And that's really the way we do most testing when clinicians recommend it. You perform a test after you notify the patient that the test will be done, for example, a cholesterol test, and consent is inferred unless the patient declines. In 2006, the CDC issued new recommendations for HIV testing of adults, adolescents, and pregnant women specific to healthcare settings. These were recommendations for providers. And they called for routine, voluntary HIV screening for all persons aged 13 to 64 in healthcare settings, regardless of risk, if the yield of new infections was at least one HIV diagnosis per 1,000 persons screened. We continue to reiterate the recommendation for screening all pregnant women during each pregnancy. And for people who have known risk factors, repeat HIV screening is indicated at least annually. Neither separate signed in consent forms nor prevention counseling needs to be required in conjunction with HIV screening in healthcare settings. This was a major departure from earlier policies for HIV testing. In 2012, CDC also issued new recommendations for the identification of chronic hepatitis C infections, specifically among persons born during 1945 to 1965, and I'll explain the rationale for this. These recommendations indicate that adults who had been born between 1945 and 1965 should receive one-time testing for hepatitis C without regard to any risk factors for HCV. For people who were not part of that birth cohort, screening is recommended for persons who have ever injected illegal drugs, persons who received clotting factor concentrates before 1987, persons who have ever been on hemodialysis, and then for persons with recognized exposures, such as needle stick injuries, or for children born to mothers who are positive for hepatitis C. I think importantly, in April of this year, the U.S. Preventive Services Task Force issued a new recommendation statement recommending that clinicians do screen all adults and adolescents between the ages of 15 and 65 for HIV infection, and younger adults or older adults who are not at are at increased risk should also be screened. This was a grade A recommendation, which is a major change for the Preventive Services Task Force. Just yesterday, in fact, the U.S. Preventive Services Task Force also issued a new recommendation statement for hepatitis C screening. And in this, the task force recommends screening, as does CDC, for persons at high risk for infection and for one-time screening for hepatitis C to adults born between 1945 and 1965. This is a grade B recommendation from the task force. Why do these things matter? Well, under healthcare reform, the Affordable Care Act, it indicates that basically these preventive health services that receive an either A or B rating from the U.S. Preventive Services Task Force must be covered by all insurance plans, by individual insurers, and at a minimum, they need to provide coverage for these specific grade A or grade B recommended services from the Preventive Services Task Force without any cost sharing, which means with no copayment and no deductible. So that this change in the task force recommendation makes this testing eligible for reimbursement for everyone covered under the Affordable Care Act or by insurance policies. I want to talk about the criteria that justify routine screening. These actually date back to 1968 when we identified the reasons that you would conduct a screening in general. Number one, it has to be a serious health disorder that can be detected before symptoms develop. Second, treatment needs to be more beneficial when it's begun before symptoms develop. Third, there has to be a reliable, inexpensive, acceptable screening test. The cost of screening has to be reasonable in relation to the anticipated benefits, and most importantly, treatment must be accessible. I think the key feature for both HIV and HCV is that indeed treatment is more beneficial when it is begun before symptoms develop. In both conditions, I think we have been used to waiting until people are at more advanced stages or are symptomatic, and we found that this does not optimize their response to therapy. I want to use a couple of examples for screening. I think everyone is used to screening for cervical cancer. That's why we do pap smears. Annually, there are about 11,200 new cases of cervical cancer and 4,000 deaths attributable to cervical cancer. By comparison with HIV, there are 50,000 annual new cases and about 19,000 deaths. So we can see that there's between 4 and 5 times as many cases of HIV. Yet it has, I think, taken a while for clinicians to get used to the idea that they should be screening for HIV the way they do for cervical cancer. We screen for rare conditions. One example is newborn screening. Every infant in the country is screened twice, basically at the time of birth and at 1 month of age. And these data, looking at the results of newborn screening, where 3.7 million infants were screened for inborn errors of metabolism, show what some of the incidences of these rare conditions. As you can see, the most common condition, hypothyroidism, only occurs in 1 out of 3,000 cases. The positive predictive value of screening for these conditions is low simply because they're so rare. By comparison, CDC recommends screening for HIV if the prevalence is greater than 1 per 1,000 from screening. So even though it seems relatively uncommon, I think that that is really much more frequent than other conditions that we screen for.
All right, doctor, I have a quick question for you before you get too far along. David is asking, why screening for HCV prior to 1987? I thought a reliable screen wasn't FDA approved prior to 1990.
I will go into this, but part of the reason has to do with what was considered surrogate screening of the blood supply. A lot of hepatitis C came from what was called non-A, non-B hepatitis. And as I started screening for other associated conditions, we saw a reduction of cases. And there was also heat treatment that was initiated in blood products that were produced after 1987. And so there's a slight difference between blood transfusions and blood coagulation products. The most important reason, I think, to look and consider screening is that screening works. Our best example is for the elimination of perinatally acquired AIDS cases. This is mother-to-child transmission. And as you can see, in the early 1990s, the number of cases peaked at nearly 1,000 per year. It was at that point in time that the ACTG protocol demonstrated the effectiveness of prophylaxis when administered to the pregnant mother in preventing transmission to her infant. Shortly thereafter, CDC issued HIV screening recommendations, and since pregnant women have been screened and prophylaxis has been begun, there's been a 95% reduction so that no more than 50 cases of perinatally acquired AIDS cases occur each year, mostly in infants who had not been screened, whose mothers had not received treatment. Looking at the magnitude of the problem in the United States, it's estimated that about 1.1 million people are infected with HIV. We've done a pretty good job at finding them. Although 200,000 people are unaware of their infection, that represents 18%, so that 72% of people with HIV do know that they have it. As I mentioned, there are 50,000 new infections each year and 19,000 deaths attributable to HIV. Looking at the HCV side of the equation, we've gotten ahead a little bit on the slides. HCV basically has a large prevalence of co-infection with HIV. It hastens the progression of HCV-related liver disease, and liver disease is a leading cause of death for persons with HCV. There are estimated to be 3.2 million people living with chronic HCV in the United States, and 16,000 deaths a year are currently attributed to HCV infection. So looking at HIV and HCV in context, there's approximately 3 times as much burden for HCV as there is for HIV, which is why I wanted to discuss both sets of screening recommendations at the same time, because the rationale is the same and the potential benefits to society are the same. This is a pattern of what HIV incidence is like since the beginning of the epidemic. What we see is in the early 1980s, there was a large increase in incidence among all population groups. More recently, among men who have sex with men, the number of annual new cases has been increasing. However, among heterosexuals and among injection drug users, the number of annual new cases has been decreasing, so that overall incident cases at about 50,000 a year has remained stable. Picture for hepatitis C is somewhat different. With HIV, because we are improving survival and having approximately stable number of new infections, what happens is that overall prevalence, indicated by the red dots in this chart, is continuing to increase. More people are living, and more people are living longer. With hepatitis C, as you see from this graph, in the early 1980s, there was a considerable amount of cases that occurred per 100,000 people. Again, many of these attributable to blood transfusion before the blood supply was screened. Initially, with this surrogate testing of blood donors, there was a decline among transfusion recipients. As the caller pointed out just a moment ago, the anti-HCV antibody test, the first generation test, was approved not until about 1994. The next generation test was approved more recently, the second generation test in 1998. And since that time, we have seen a significant and continued decline in the incidence of new cases of hepatitis C infection. This decline in particular has now occurred among persons who inject drugs as well as among persons who are recipients of transfusions. I'm having some trouble moving on. The future burden of hepatitis C, however, is very different than its current incidence. There are about 2.7 million HCV-infected persons in primary care. We estimate that nearly 1.5 million will develop cirrhosis, about 350,000 will develop liver cancer, and overall 900,000 will die from HCV-related complications. This is, however, related to chronic disease. So if we look at basically the pattern of HCV infection, sorry, I'm having a little trouble with advancing the slides. What we see with the pattern of HCV infection is that the number of cases of hepatocellular carcinoma and of cirrhosis and of deaths attributable to hepatitis C, if we leave things untreated, is not going to begin to peak until the 2020s, because what we're talking about is a different cohort of people who are infected with HCV, and these complications occur substantially after initial infection occurs. This is a pattern looking at the year of birth for people and HCV prevalence. And what you see is that in people who were born before 1945 and people born after 1970, prevalence is relatively low, less than 1%. But in this interim period, between 1945 and 1965, between 4% and 5% of people have hepatitis C infection, most of whom don't know it. This particular birth cohort between 1945 and 1965 represents, we're really going to need to get this working better. It represents 81% of all adults with chronic HCV infection. This cohort, born between 1945 and 65, the baby boomers, represent 73% of HCV-associated mortality, and in surveys, nearly half of people with HCV do not report a risk factor for HCV infection. This next slide basically shows the pattern of HIV and HCV mortality. The red bar along the top, the red line, indicates what we've been seeing with patterns of death rates for HIV, which have been consistently decreasing since effective therapy became available in the late 1990s. The mortality associated with HCV, on the other hand, has been increasing, and in about 2006, the number of deaths attributable to HCV actually began to exceed the number of deaths attributable to HIV each year. So what is the rationale for expanded screening? Number one is the medical rationale. Treatment is effective. At the current time, treatment is recommended for all persons with HIV infection, regardless of their CD4 count. As I'll show you, treatment also works for HCV infection with similar benefits as those for HIV. This slide, I think, is a picture that tells 1,000 words. The blue curve is the percentage of patients on highly active antiretroviral therapy, and as that proportion of patients increased, death rates from HIV plummeted dramatically. And as you can see, in 1996, with the introduction of triple therapy for HIV and the protease inhibitors, those two curves crossed. Therapy increased and deaths substantially increased, and we continued to see declines in mortality from HIV. This is an example of the per-person survival gains with various different disease interventions, starting with, for example, chemotherapy for lung cancer on the left, for adjuvant chemotherapy for breast cancer in the second block, and way to the right we see antiretroviral therapy for persons with HIV and AIDS. And this indicates that the per-person survival gains is approximately 10 years from antiretroviral therapy, and this was when therapy was not begun until people had diminished CD4 counts. And so the benefit from antiretroviral therapy are in fact better than the therapy, the particular therapy for acute MI in coronary arteries disease, for example. The other issue for early therapy for HIV is that we get substantial benefits with very little extra cost. So that, for example, when a person is diagnosed late with a CD4 count of less than 200, their life expectancy, if they're started on treatment, is about 8.5 years, and their lifetime medical costs $192,000. If you start therapy early, when a CD4 count is greater than 500, we get 3 times the survival benefit, about 25 years additional life expectancy at a cost of only $230,000 lifetime, only about $30,000 more than when therapy is started late, despite a 3 times as high benefit for survival. HCV is a very, very similar situation. Therapy can cure HCV infection. It's called sustained virologic response. And sustained virologic response for HCV is associated with a 70% reduction in hepatocellular carcinoma and a 50% reduction in all-cause mortality related to HCV. This graph depicts the advances in HCV therapy. I think most people are sort of familiar with the era of pegylated interferon or interferon in ribavirin. And at the current time, with the introduction of now what's called direct-acting antiviral therapy, which are protease inhibitors, we are seeing a greater than 90% response rate, so that we're seeing tremendous strides in treatment for HCV infection.
Doctor, if I may, before you move on to a new topic, Dan has a question about the testing. How about screening among pregnant women? Can it be considered as routine for prevention of perinatal transmission?
It is actually one of our major successes. More than 70% of pregnant women are screened. It is definitely considered routine. It has been recommended actually since 1994 by the American College of Obstetrics and Gynecology, and it quite clearly is routine. We in fact would like to see screening become as routine in other populations as it already is in pregnant women.
Okay, great. Thank you.
I think the next major issue that is really important related to screening is that treatment, in fact, prevents transmission. We're talking about infectious diseases here. Treatment benefiting an individual is something that we're used to. But first of all, when people find out that they're HIV infection, they are less likely to transmit simply because they change their behavior. So in this meta-analysis of a large number of studies of high-risk sexual behavior, we saw a 68% reduction in unprotected intercourse with HIV-negative partners among people who knew they had HIV compared to people who were unaware they had HIV. Behavior change is important, but perhaps the most dramatic study came out last year in the New England Journal. It was called HPTN 052 from the HIV Prevention Trials Network. And this was a study which compared partners in a partnership where one person was infected and the other one was not when therapy was initiated early, and it demonstrated a 96% reduction in HIV transmission when people had been started on antiretroviral therapy. Virtually all people who were started on therapy no longer transmit HIV infection, which is a really, really dramatic influence and gives us this opportunity of something called treatment as prevention. This is where the concept comes from, that putting people on therapy is not only good for them, but renders them uninfectious to other individuals. Treatment as prevention is got as a goal to increase the percentage of persons who have viral suppression. Viral suppression, i.e. having an undetectable HIV viral load, is a function of testing, getting people linked to care, having people remain in care, receiving antiretroviral therapy, and adhering to the antiretroviral therapy. There is a continuum looking at these factors, and in the United States, we currently estimate that of the people who are infection, of the 1.1 million people who are infected, about 80% know that they are HIV infected. And so testing has resulted in an 80% rate of people knowing they're infected. When we look then at the number of people who are linked to care, 62% of the people who are infected have been linked to care. Only about 41% of people remain in care. And perhaps for some time, this was because not everyone who was HIV infected was eligible to receive therapy. Of those who are in care, about 38% are receiving antiretroviral therapy. And so overall, looking at viral suppression, only 28% of people who are HIV infected in fact have an undetectable viral load and therefore are unable to transmit. We obviously are seeking to increase each one of these aspects of the continuum in order that the majority of people with HIV infection will have undetectable viral loads. Antiviral therapy might also be used to reduce HCV prevalence, especially among injection drug users, which is the group among whom it is currently continuing to spread. Looking at the HCV continuum, it's a little bit less optimistic. Of all the people who are HCV infected, only about 50% of them are aware of their infection. About 38% of them are in HCV care. Of the people who have had an HCV RNA test, meaning that they have active infection. About 31% of those infected have been identified. Only 18% of them are treated, and only 14% have achieved a sustained virologic response, meaning that they're uninfectious and, in fact, cured of their hepatitis C. I think the other thing that people have been used to for a long time is risk-based screening. Risk-based screening, unfortunately, misses many people who are infected, and I'd like to give an example. In South Carolina, they looked at all the reported cases of HIV that were reported between 2001 and 2005. They there have a registry which allows them to confidentially match all the healthcare visits that occurred in the preceding 9 years at emergency departments and inpatient facilities and surgery facilities and in medical clinics. Looking at the 4,300 reported HIV cases, they identified that 3,200 people, 73% of them, had made a total of 20,000 healthcare visits before they ever were tested for HIV and found to be positive. Looking at the diagnoses during these visits, at 77% of those prior visits, the diagnosis code that was recorded would not have suggested the need for an HIV test. They went further and they looked at the people who had developed AIDS within a year. This meant that by the time they were this far advanced in their HIV infection, there was no question that they were infected with HIV during their earlier visits. And the percentages are the same. 73% of people made about 8,000 previous healthcare visits, an average of 4 per patient, and were not tested for HIV. Even though their disease was advanced, the diagnosis codes in nearly 80% of those prior visits would not have prompted a clinician to order an HIV test. So that symptom-based or risk-based screening failed to identify people. This is the reason I think that there has been a major push in order to do screening for people who are asymptomatic so that we don't continue to miss these particular infections.
Quick question, doctor, before you move on. Dan is asking, what is the most effective function of ARV to HCV?
The most effective function?
Yes.
I think they're very, very parallel. The new therapeutic agents for HCV, the protease inhibitors, are very, very similar to the drugs that are being used for HIV. And so we have very parallel evolution in those two fields, that we get effective antiretroviral therapy, effective anti-hepatitis C therapy with the same kind of agents that actually act at the virologic level in order to suppress viral replication.
Thank you.
A little trouble getting the slide to move on. The situation for HCV with respect to risk-based strategies is the same. CDC had previously recommended risk-based screening on the basis of injection drug use, blood transfusion before 1992, but clinicians may be reluctant to ask about risks, and frankly, asking a person about something that might have happened 50 years ago, they may not recall that they had a risk, or they may be unwilling to disclose it, so that anywhere between 45 and 85% of people with HCV are unaware of their infection. I want to talk a minute now about acute HIV infection, which I think is something that we have recognized increasingly that's important for driving the epidemic. For clinicians, the clinical syndrome when a person first acquires acute HIV is such that 40 to 90% of people develop symptoms. 50 to 90% of these people have symptoms that are severe enough to cause them to seek medical care, where, unfortunately, they're not likely to get diagnosed. Looking at a series of people diagnosed with acute HIV infection, 50% of them were seen at least 3 times before someone did the appropriate test to establish the diagnosis. Why is that? It's because the manifestations of acute HIV are those of a viral illness, so that while 85% of people have any kind of symptom, in the majority of cases this is fatigue or fever or pharyngitis or lymphadenopathy, things that we're used to seeing with infectious mononucleosis or with other viral illnesses. They would not necessarily prompt you to think of HIV infection. However, if we look at the frequency of acute HIV among patients who are seeking care, in one study where they looked at individuals who were evaluated for infectious mono, 1.2% of them, in fact, had acute HIV infection. Among another group of patients evaluated in urgent care settings for acute viral illness, again, the percentage was over 1% who actually had acute HIV infection. Most recently, in fact, just last week, CDC published an MMWR report. In Phoenix, an emergency department that was following CDC's recommendations for screening patients conducted screening with a 4th-generation test, and I'll describe that in another moment. They conducted HIV screening on all patients who had blood drawn in the emergency department for any reason. Only 15% of patients actually declined testing. Out of the 13,000 patients who were detected, they found 37 new HIV infections, but importantly, 12 of them, 32% of all the HIV infections were in fact acute HIV infection, people who were antibody negative. This seems to be evidence that in fact people who use emergency rooms for their primary care are seeking care for the symptoms of acute HIV infection. Why is acute HIV important? There are several reasons, but the primary one is related to transmission. This is a graph showing the concentration of HIV in semen over the course of infection and the risk of sexual transmission of HIV. And what we can see is that during this very brief initial period, the risk of infection is somewhere between 10 and 100 times greater. That's the risk of transmission because of the very high levels of virus. One other thing that we found is that the virus that is present, the virus that actually manages to establish a new infection, is different. It's somewhere between 75 and 750 times more infectious than the strains of virus that are present during the long asymptomatic period of HIV infection. In addition, people with acute HIV infection tend to behave differently. In this study from North Carolina, people with acute HIV infection named 2.5 times as many sex partners, and when their sex partners were interviewed and tested, nearly twice as many of their sex partners were newly diagnosed with HIV compared with people who had established HIV infection, who had HIV infection for a long period of time. So that controlling the epidemic now ends up depending on finding acute HIV infection. And it's particularly common among men who have sex with men, although the actual incidence of acute HIV infection is relatively low. Because of the tests that we've been using, antibody tests, people with acute infection that is antibody negative represent anywhere from 10% to 20% of all the infections that are detected when people seek testing. Which brings us to the topic of what tests to use. For HIV, tests come in generations, and I sort of use the parallel of the 4 generations, sort of what we've come through with the evolution in telephones, back from the old rotary dial phones up to the new smartphones. It's a similar kind of pattern for HIV. The first generation tests were made of whole viral lysate. They detected only IgG antibodies, the second antibody to develop. Second generation tests were a little more sophisticated. They used synthetic peptides that were more specific, but still detected only IgG antibody. The third generation tests detected both IgM and IgG antibodies, so they picked up infection a little bit earlier. And in 2010 and 2011, the FDA approved fourth generation tests. These tests detect IgM antibodies, IgG antibodies, and also a viral protein called P24 antigen, which allows them to detect infection much sooner after a person gets infected. There are now also nucleic acid tests specifically to detect HIV RNA, and there is some terminology that the FDA uses. COM-B tests with an I are those that detect antibodies to both HIV-1 and HIV-2. Combo tests, like the fourth generation, are those that detect both antigen and antibody against HIV. What I'd like to do is sort of go through what the meaning of the different evolution of these tests are and see how it sort of impacts in what physicians order in terms of testing. This is a schematic of a cartoon of what happens with laboratory markers during HIV infection. Infection itself occurs far there on the left at point 0. The first thing to appear is HIV RNA in plasma about 10 days after infection. Then the viral P24 antigen appears, but it's transient. It goes away shortly. And subsequently, antibody begins to appear and continues to increase through the course of infection. The first generation tests picked up infection somewhere between 50 and 60 days after the time of infection. And so there was a long period of acute HIV infection between the time RNA appeared and people became infectious and the time the test picked it up. Second generation tests did a little better. They shortened that window period to about 45 days. The third generation tests, which are the ones in major use in all laboratories, did even better than that with a much shorter window period in the range of 15 to 18 days. And the fourth generation tests make that interval even shorter, only about 5 to 8 days after the time RNA appears before the test will detect infection. Looking at the evolution, this is going to be just sort of a quick one, seeing sort of what happens with the tests coming and go since the beginning of the epidemic. As new tests were introduced, other ones were withdrawn from the market. However, under the FDA, once a test is approved, it can't be unapproved. And so at the current time, as we have on the market first generation tests, second generations, and third generation tests, and the paradox is that our screening tests that are used in the laboratory are all third and fourth generation with very small window periods. The rapid point of care tests are second generation tests with longer window periods. And unfortunately, the tests that have been used characteristically for confirmation, the Western blot or the immunofluorescence assay, are first generation tests. And so we now are in a situation where our screening tests pick up infection before they can be confirmed by our confirmatory tests. This is an uninterpretable slide of a study from CDC's laboratory looking at all currently FDA-approved tests with a series of seroconversion panels to see when they detect infection. In order to make sense out of it, we basically looked at what was called 50% cumulative frequency, when each of the tests detected 50% of the specimens of people who were seroconverting. This timeline compares all of those to the Western blot. The Western blot is the classic confirmatory test, at least until now. The Virinostica, which was in widespread use until 2007, didn't detect infection until a couple of days after the Western blot, so it was a very good test for confirmation. On the other hand, the Aptima, which is the RNA test, will pick up infection 26 days, nearly 4 weeks before the Western blot is positive, and people are infectious during that entire interim. Looking at the other groups of tests, these represent the CLIA-waived fingerstick rapid tests. When they're performed on serum, they pick up infection between 2 and 7 days before infection. There are other laboratory-based rapid tests called flow-through tests that pick up infection a little bit earlier. But importantly, the current laboratory assays are all third-generation assays shown here in blue. They pick up infection about 2 weeks before HIV infection. The most recently approved fourth-generation tests pick up infection about 3 weeks before the Western blot turns positive. And right now before the FDA is a rapid fourth-generation test that again picks up infection much sooner than the Western blot is able to confirm it. What this means is we need to have a different diagnostic approach in terms of the tests that we use. The Western blot algorithm that's been in place since 1989 is no longer effective. It does not detect infection in about 10% of people who are infected and have the highest risk of transmission. It's less sensitive than many of our screening tests during early infection, and obviously the delays inherent with its complex processing in laboratories means that some people don't receive their test results. I just want to spend a moment on HIV-2 infection. It's relatively uncommon in the United States, but it doesn't respond to the main therapies, the non-nucleoside reverse transcriptase inhibitors and some of the protease inhibitors that are first-line therapy, and it's not detectable by viral load tests.
Doctor, if I may, before you get too deep into HIV-2, there's a question about the P24 antigen. Why does the P24 antigen disappear from the blood so fast in a productive viral infection? The P24 antigen should be constantly produced.
P24 antigen is constantly produced, but it binds with antibody, and so as soon as antibody begins to increase, it essentially combines with the P24 antigen, and although the antigen is still there, you can't detect it because you can't dissociate the antigen from the antibody. HIV-2 I won't spend a lot of time on, but I think it's important for clinicians to recognize that more than 60% of HIV-2 cases are misclassified by the Western blot as HIV-1. Therefore, HIV-2 is often not diagnosed until the person deteriorates immunologically in a person who's got otherwise a viral load. Which brings us to CDC's recommendation for the new HIV testing algorithm. This was described in last week's MMWR, and the formal recommendation is currently in process. This calls for laboratory screening to begin with a fourth-generation HIV-1, HIV-2 combination immunoassay. If that test is positive, you conduct an antibody test, particularly an antibody test that is designed to discriminate between HIV-1 and HIV-2 antibodies. If the first test and the second test are positive for antibodies, the person is considered to have HIV-1 or HIV-2 infection established. If the first test is positive, the sensitive fourth gen test, and the second antibody test is negative, then the specimen should go on to be tested for nucleic acids, for HIV RNA, in order to identify people who have acute HIV infection.
Quick question, doctor, from Yvonne. She asks, our clinic uses rapid tests and Western blot. Is the confirmatory test, does this mean that when the rapid test is positive, there is not need to do the Western blot due to the delay in detecting positivity?
Unfortunately, rapid tests can also be false positive, and so there is no such thing as a single test that you do for HIV. Whether it's a rapid test or a laboratory test, follow-up testing is necessary in order to establish that with certainty infection is present. As I mentioned, there are shortcomings to the Western blot because of the difference in detection, which is why we are now advocating this different algorithm, so that a person who uses a rapid test should send a specimen to go through the same testing process with the fourth generation test, and if necessary, with a nucleic acid test in order to be able to pick up infection. We've looked at performance evaluations of this new algorithm and found that it is equivalent to the Western blot for people who have long-standing infections. However, it detects many more early and acute infections. It produces fewer indeterminate test results. I think most clinicians are familiar with indeterminate Western blot. It has much faster turnaround time for test results, and fortunately, its cost is equal or lower than what our current practice is. So as I mentioned, the draft recommendations are to initiate screening with a 4th-generation combination immunoassay. If that test is reactive, you then conduct an antibody test that differentiates HIV-1 from HIV-2 antibodies. And for persons who are reactive on both of those two, they should be considered to have HIV infection and enter care for their subsequent testing, like their viral load, their CD4 count, and antiretroviral resistance. Again, specimens that are reactive on that first sensitive initial assay and negative on the second should go through and get nucleic acid testing. And as I mentioned to our recent caller, the same testing algorithm should be followed for people who have a previous reactive rapid HIV test result. Comparing RNA testing versus this 4th generation, what we have identified is that the 4th generation antigen antibody test picks up more than 80% of people with acute HIV infection that would otherwise be detectable only by RNA. But RNA is a great deal more expensive. The 4th generation test picks up infection about 4 days after the RNA first appears, and so this algorithm will be able to detect the majority of people with acute HIV infection. Just to show some of the examples that are in use in hospitals right now, we now have what are called random access EIAs. This is the Architect 4th generation assay. Its time to a test result is only 29 minutes, and so the concept of rapid testing is also changing. This is a rapid result without a rapid test. The Biorad, this is the other FDA-approved 4th generation test. This is a standard microwell plate EIA that is done in laboratories, approved in 2011. As I mentioned, there is the Aptima qualitative RNA assay that has been approved for confirmation of HIV infection and for use in this algorithm. And interestingly, the HIV-1, HIV-2 differentiation assay is in fact a rapid test. It can be done in only 15 minutes in most laboratories. So that with the initial test, for example, the Abbott Architect, taking 29 minutes, if that's positive, the second test takes only 15 minutes, we could essentially get a confirmed diagnosis of a person who is antibody positive in less than an hour, which is a substantial improvement over what we've been seeing for confirmation until this point in time. So the implications of this is that we will now have the ability to detect acute HIV infection, which serves as a focus for partner services and for intervention efforts. And recent information also indicates there is substantial clinical benefit from treating people during the acute phase of HIV infection in improving the long-term course of their disease. There is, from CDC, a new surveillance case definition for what is called stage 0, people who have been infected in the last 6 months. And the new algorithm will also give us the ability to detect HIV-2 infections and look specifically for what we need to do in terms of therapy, since HIV-2 does not respond to all HIV-1 therapy. For people who are used to the Western blot, it's been hard to let go, and we have established a support group because I think that we've been used to this for the last 20 years, and it's sort of hard to accept change when, until now, the Western blot has been the sine qua non. For HCV, there is also a new testing algorithm, and this one is important because we need to identify the people who are in need of therapy. HCV testing starts, again, with an antibody test. If that antibody test is positive, it is recommended that people get tested for hepatitis C RNA. If that RNA is positive, it indicates that the person has active hepatitis C infection. They should be linked to care and start on therapy. If that RNA test is negative, it indicates that there is no current HCV infection present. It is possible that the initial antibody test might have been false positive, and so if it's important to determine whether HCV infection never occurred or whether it's no longer present, additional testing might be indicated as appropriate, since with greater screening, we will be identifying more people with HCV antibody infections. In terms of clinical settings, I know that one of our questioners asked about rapid tests, but for regular patients in practice settings, if their follow-up can be assured, we should send specimens to the laboratory. The specimens for HIV and HCV testing, laboratory tests, are more sensitive than the point-of-care rapid tests. But for transient or walk-in patients or emergency department patients for whom follow-up might not be assured, that's the place to consider using a rapid test with same-day results. And for those with reactive test results, as I mentioned, they need to have follow-up testing. It's important, in particular for hepatitis C, that people with positive antibody test results for hepatitis C get additional testing with the nucleic acid test to identify those who have active infection who are in need of treatment. Just a quick moment on the horizon. We're not at the end of what we're doing with IV or HCV testing. There is a 4th generation rapid test that is currently before the FDA for consideration, which would allow at the point of care in 10 minutes to detect infections much earlier. There is a new supplemental test, which is similar to the Western blot, except it's also designed to be used with a finger stick specimen. It differentiates HIV-1 from HIV-2. It has an automatic reader and takes only 10 minutes in order to generate the test results. And then there are some additional amplification-based assays that are becoming available that should be able to give us nucleic acid amplification test results in less than an hour. So for me, a lot of things have changed since the days when I was in practice. We've really moved on tremendously in terms of both HIV and HCV therapy. For the things I mentioned today, this is a list of resources that are available on CDC's website, including the revised recommendations for screening, both for HIV and for HCV, and the updates on the laboratory testing for HCV infection and HIV infection, some of which just came out this year. And so encourage people to visit the CDC's website and look for these recommendations both for screening and for what tests to use.
All right, Doctor, thank you. We do have a couple of more questions. There's a couple more minutes, so if you have any questions, please get those in now as we're down to about 5 minutes left in the presentation. I'll start off with a question from Yvonne. She wants to know, are providers utilizing the opt-out criteria for doing HIV testing?
Increasingly, we are seeing providers using opt-out. When the CDC recommendations first came out, nearly half of states in the United States still required a signed, separate informed consent form. Most states, in fact all but Nebraska, have rescinded that requirement, which permits physicians to do opt-out testing. What we find is patients are much more likely to be tested, and they don't feel like they're being singled out on the basis of some risk factor, and so that has really gained widespread acceptance.
Yeah, I find that can be an impediment at times. Another question coming in, HIV AB plus by Elisa 3rd generation, but the Western blot only P24 positive. Is this acute or no infection?
It's probably most likely acute infection. The only way to tell is with the nucleic acid test. Western blot P24 is an indeterminate, and with a 3rd generation test being positive for antibody, the Western blot with P24, it can either be evolving and still not fully positive, so you could potentially repeat that test in 2 weeks. On the other hand, cross-reactivity with P24 is one of the most common reasons for a false positive Western blot, and so the only way really to tell the difference there is to repeat testing with the test of time, or to test specifically for HIV RNA in order to establish where infection is present.
Gotcha. Doctor, now earlier you mentioned the new recommendations for hepatitis C, and I was just wondering personally, you mentioned some of the implications for insurance. What are the larger global implications of that in terms of what we're talking about in the topic of discussion?
I think that the real implications for HCV testing is the need for an awareness that, number one, we can make a huge difference. Number two, therapy is effective. And number three, if we don't do anything, there's going to be a huge burden over the next 15 years of people who could have responded to therapy and had a very normal life expectancy. Hepatitis C is the most common cause of hepatocellular cancer. It is a very common reason for people to require liver transplants, and we can avert all of those complications by essentially identifying people with a very simple test and then getting them on effective therapy.
All right, another quick question coming in from Jeffrey. Will an MMWR be released that discusses the new algorithm without the Western blot?
As I mentioned just last week, there was an MMWR on June 21st that looked at the algorithm and 2 evaluations of the algorithm. The specific CDC recommendation, which will contain this new algorithm, is in process, is anticipated in the near future.
All right, Doctor, as you know, we do have a global audience, so there's a question coming in regarding sort of this price and practicability. As you said, tests should also be affordable. Which one can be recommended for use in limited resource country settings, for instance, Africa, where more is HIV-1 positive? Do we necessarily need to check also for HIV-2?
Most of the tests that are available in Africa, in fact, at the current time, already screen for both HIV-1 and HIV-2. Africa, obviously West Africa, is the place where prevalence of HIV-2 is highest, and so it makes a difference where your region is. In terms of cost-effective tests, the developing world led the United States in introduction of rapid HIV tests. The 4th generation rapid test that I showed you is already available outside the United States, and so that test at a very reasonable price can be employed for screening there. The real issue is what has to be done to confirm the presence of HIV infection. Until now, outside the United States, it has been a frequent practice to use 2 rapid tests in combination, and if both are positive, to consider a person to be positive. More recently, there has been evidence that, in fact, sometimes that fails to diagnose people correctly so that they get an HIV diagnosis when they don't, in fact, have HIV, which has very serious complications. And so there is an increasing movement to use these simple, inexpensive tests for screening, but then for the people found to be positive to use somewhat more sophisticated techniques in order to make sure that the positive answer is the right answer.
All right, Doctor, we have just about a minute remaining. I want to give you an opportunity to perhaps wrap up your presentation, maybe some final comments so that folks can take away with them.
I think the most important thing is that we need to be screening for HIV and for HCV infection. It's got benefit for reducing transmission. It's got benefit for individuals. It's been shown to be cost effective. We also need to use the right tests in order to do this screening. The issue of acute infection with HIV, with active infection with HCV, is really a new concept that is driving the epidemic. At the current time, the one topic we didn't really talk about today is PrEP, pre-exposure prophylaxis. That's providing treatment for people who are uninfected in order to keep them from acquiring HIV infection. They, however, must be established to be negative, to be uninfected before you start that therapy. Otherwise, it has implications for developing resistance. And so the concept of testing, using the most sensitive tests for people to make sure they're negative or to, when they're positive, get them on therapy, is, I think, the most important message I'd like people to walk away with.
All right, great, Doctor. Thank you very much for this incredible presentation. We really appreciate you coming in and being with us today.
Thank you.
All right, we appreciate that. I also want to thank Gilead Sciences, Boehringer Ingelheim Pharmaceuticals, and Vertex Pharmaceuticals for their support of this important educational series, in addition to educational support provided by the Centers for Disease Control and Prevention. Now, please remember to complete the quiz at the end of your session to secure your CME credit, and stay tuned for more. The next session is titled New and Emerging Treatments in HIV Infection with Drs. Calvin Cohen and Paul Sachs. Thank you very much for joining us today. For all of us here at ID Care Live, thanks again and have a great day.